so much. So I would say this is a tough topic because it's an evolving topic. And I don't think we are at a place where we have complete guidelines. And I thought it might be more interesting or informative to just sort of do a few cases and then use them to reflect on how we might use molecular classification at this time. So I'll start with one patient, a 73-year-old, who underwent the standard staging laparoscopic HIST-BSO node for endometrial cancer. She had a grade 2. It was 35% myometrial invasion. She did have lymphavascular space invasion. Her mismatched repair proteins were intact. She was p53 wild type, and she received vaginal brachytherapy because she was an intermediate risk because of her age and the grade. However, about 6 months later, she, on routine screening, was noted to have multiple pulmonary nodules and had a biopsy that showed metastatic endometrial cancer. She received the standard carboplatin Taxol therapy. She had progressive disease. She was then treated with anti-estrogen therapy. She had stabilization. And she was treated with the fulvestrant, the anti-estrogen therapy, because she was ER receptor positive. And she then had another biopsy. She had a few more molecular studies for this, and it was thought to be what's called a mesonephric type adenocarcinoma. So with that as a background, just to think she had what's called a non-specific, sort of non-marker, a high-risk endometrial cancer, but she had estrogen receptor positive. So there's this one interesting study that looked at ER-positive cancers and sort of wondered about their prognosis. And they kind of had a group of over 600 patients. They classified them into high-grade, low-grade, serous, clear cell, and so forth, and then studied how they did. Just to remind you about PORTEC-3, that was a randomized, huge study that randomized in high-risk patients to radiotherapy versus chemoradiotherapy. And what was interesting about PORTEC-3 was they also, divided up by the categories of molecular testing. So they looked at p53 mutations, they looked at POL mutations, they looked at mismatch repair, and so forth. And basically, sort of were able to classify these 600 plus patients in that way. And what they saw was what we kind of knew from the human genome study, that basically prognosis was related to molecular markers. p53 was a poor mutation, was a poor prognostic factor. POL-E mutation was a good prognostic factor, and everything else sort of divided out in the middle. So this patient had a endometrial cancer of no specific molecular profile, and that's looking at the human genome atlas. This is the copy number low p53 wild type group, and the question is, what do we do about them? So at Mass General, our current algorithm for molecular testing is we do mismatch repair proteins on every one of those 4 gene mutations. We do p53 and we do estrogen receptors. We don't standardly check for POL-E unless there are other features that might suggest that. And so if we think about this particular group, it's predominantly endometrioid. It's predominantly grade 1 to 2, although there are some grade 3s. And when we think about how to sort of risk stratify this particular group, we sort of can, in this group, think about using a POL-E mutation to see if we need to do other therapy or not. So that's sort of, you see here from the sort of information we have about molecular testing that the ultramutated POLE has a very good survival compared to the serous copy number high group. All right, so my patient had a mesonephric-like adenocarcinoma. There's various features where you take a look for immunohistochemistry, look at estrogen receptors. These are much more aggressive, and you see distant metastasis as we did with this patient. In the setting where there are estrogen receptor positivity in this group, you will see a reduced risk of recurrence if they're ER positive and you give them an anti-estrogen. So this particular graph that you see here is your standard molecular survival graph, but includes the no specific mutation ER positive and negative. When you divide them up, you see the orange line is the ER positive. They're almost as good as POLEs. Very interesting. Okay, so how to put this all together. When we risk stratify, we have low risk, which is grade 1 to 2, ER positive, high risk, which is grade 3, ER negative, non-endometrioid subtypes. We know about that. There are other mutations that we don't know are ones we can use to make prognostic information. But we do know that the ER positive has a very different survival rate. So with that in mind, we can use the rainbow sort of algorithm that looks at molecular classification to help us with decision-making about adjuvant therapy after surgery. So just to walk through this, if you have p53 mutation, you would consider either chemoradiotherapy. Sometimes you might add olaparib if you are HRD, which is not often in endometrial cancer. If you are mismatch repair proficient in a high-risk patient, you would just do radiotherapy. But if you were mismatch repair deficient, you would add immunotherapy. For those with no specific mutational profile but are ER positive, you would add an anti-estrogen or a progestin after your radiotherapy. And for those who are POLE mutant, you could maybe de-escalate therapy. We haven't yet had the courage to do that in our very high-risk patients who are advanced stage, but it's something to reflect upon since they seem to have such a good prognosis. How are we doing for time? Okay. So, in terms of mesonephric-like adenocarcinomas, they're a small group. About over 50% will present with advanced disease, and they have a high rate of lung metastasis. I think the current guidelines are to consider doing estrogen receptor checking, and there's other studies that have looked at the combination of targeted therapy with anti-estrogens in this setting. Okay, I'm going to just go in the interest of time to one more case looking at using HER2 receptor checking. So here's another case. This is a 63-year-old presented with bleeding, had a biopsy that showed endometrial cancer, and underwent a laparoscopic hysterectomy, BSO, lymph node, sentinel node biopsies. She had a mixed serous endometrioid adenocarcinoma. Her cancer was p53 mutant, mismatch repair proficient. And she had a stage 3A nodal 1 cancer, and she was HER2 positive. She had imaging studies that suggested that she had stage 4 disease based on her imaging. And so she was treated after surgery with a combination of carboplatin, Taxol, and trastuzumab, which is Herceptin, because of her HER2 positivity. So that was how she was managed. And she had progression after 9 months and then was treated with immunotherapy and had 24 cycles, but had progressive disease following this. And then she received, again, the Herceptin, the trastuzumab, attached to another sort of antibody directed therapy. And this is one that's an experimental one called Deruxtecan. She actually had a complete response after all this progression on this particular regimen, and she continues to be on this regimen as a maintenance. So it's a very interesting case. So with that in mind, just to summarize, this was a woman with a stage 4 high-grade serous with p53 mutation and HER2 positivity. So HER2 is something we don't think about outside of breast cancer, but there is a subset of endometrial cancer where there is HER2 receptors. And basically, you have this overexpression that's been identified first in breast. It's been also in gastric tumors and also now in uterine serous. So we have a testing algorithm of scoring HER2 as 0, +1, +2, and +3. +3 is HER2 positive. And there's a lot of information and discussion about interpreting the immunohistochemistry around HER2, which I won't go into with our lack of time, but just to say it's an area of great debate and great analysis to be sure that you're really only targeting those who are truly HER2 positive. Okay, so then we have our antibody drug conjugates that this agent is one of, that are now added to Herceptin that can help deliver the Herceptin and the drug. So in terms of indications for HER2 testing nowadays, we do it in serous carcinomas, in carcinosarcomas, and other endometrial cancers that are endometrioid but have p53 mutations to consider doing that. There has been some look at doing HER2 testing in other cancers such as ovarian, cervical, and so forth, but the chance of them having positivity is quite rare. Okay, let me just check our timing. This is just a survival, progression-free survival looking at serous HER2 positive cancers treated with trastuzumab, with carboplatin and Taxol versus not. And you see that there is a significant difference in survival. So it is definitely should be part of your standard chemotherapy protocol in this group of patients who have advanced disease, who need to be on systemic therapy and so forth. And here's another survival curve showing you the difference, those treated with trastuzumab versus those not, the green being the trastuzumab. The deruxtecan in recurrent carcinoma has been looked at and carcinosarcoma, and this particular ADC with Herceptin trastuzumab has also shown efficacy. And there's other labeled studies. I'm just going to stop there, but just to say, there's information that's sort of case by case with good early clinical trials using molecular markers. And estrogen receptors should be looked at, and you should be thinking about that as part of your treatment decision, in addition to looking at the molecular markers. And in the setting of high-grade serous and p53 mutant, to consider or definitely look at the HER2 receptors and consider trastuzumab in the setting of them being positive. I think what's going to happen is we are slowly going to build case by case and clinical trial by clinical trial regimens of treatment that are molecularly based. And that's sort of my message, is I'm showing you two patients where we sort of did that and actually was beneficial for both those patients who initially looked to have terrible, terrible prognoses. And so we will continue to work on this, so stay tuned for more information. But thank you so much for the opportunity.
Thank you, Dr. Kathryn Goodman, for your very difficult